Okay, so here we go on Unit 20, excuse me, Fluid and Electrolytes. This is for medical surgical nursing, semester 1, nursing 162 at Santa Barbara City College. And the professor is Ayman Amin. So yeah, today we're going to go through some fluid and electrolytes. Our goals for this are going to be to explain fluid and electrolyte regulation and balance. We're going to explain exactly what the role of the nurse is for caring for patients with each imbalance. We're going to explain the acid-base balance and go over what the role of the nurse is when caring for patients with the acid-base imbalances. Okay, so let's start off with body fluid compartments. For the body fluid compartments, we are going to have 60% of our total body water volume. Up here, this is going to be 60% of our body weight is water, and that's 40 liters average for adults. Um, about 40% of the total body weight, or about two-thirds, 66% of the entire water weight of the body is contained in the intracellular fluid. So that's within the cell itself. Beyond that, there's extracellular fluid that accounts for about 15 liters of that, or about 33% of the total body water content. Um, this is comprised of interstitial fluid, the fluid that is in between cells, so in the extracellular space. This has to do with lubricating fluids like in the pericardial sac or the pleural sac. Um, it has to do with a lot of different areas. But in between cells, about two-thirds of just the one-third, or let's say three-quarters, so 75% of the entire extracellular fluid is contained in interstitial fluid. The other quarter, so 25% of the extracellular fluid volume, or 20% of the total, um, or whatever, excuse me, 5% of the total, 4% of the total ECF, total body fluid. Gosh, this is getting me confused, but we're going to push on. Yeah, so um, this is the body fluid compartments. Next, let's look at some electrolytes here. So the body is made up of this water, but it's not just plain pure water. It contains many different electrolytes. These tend to be potassium, sodium, chloride, calcium, phosphorus, and magnesium. Um, these provide a variety of different functions. We're going to go into each one in their specific ones, but these are the primary six electrolytes that we're concerned about. So just some precursor here to the rest of our lesson. Hyper, the abbreviation hyper is going to refer to anything above the normal range of the electrolyte. Hypo is going to refer to anything below that normal range limit of each one. So I included this little diagram here um, just to show. I I know Gatorade is the most common electrolyte drink that we have in the United States, but I actually used a different kind with less sugar and less total carbs, as you can see here, called Scratch Labs, and I was just curious to see what that looked like. So you can see here just the potassium content of um, each individual drink, some sports drinks compared, that type of thing. So let's start off with sodium. I'm going to go through, took pictures of this little cell here with the intracellular fluid and the extracellular fluid. And I'm going to just add the electrolytes where they appear in higher concentration as we go along. So starting with sodium, the function of sodium is to regulate water inside and outside of cells, so the fluid balance inside and outside of cells. More sodium will bring more water into the cells. Less sodium will bring less water into the cells. But it is mainly concentrated on the outside of cells. It's involved in muscle contraction and conduction of nerve impulses. So our normal range for sodium is 135 to 145 milliequivalents per liter. Um, this range is pretty specific, and uh, values outside this range can indicate some severe problems. So as we said, um, the higher concentration of sodium is outside the cell. Hypernatremia we would uh, quantify as anything above 145 milliequivalents. In this case, hypernatremia, the cell above 145, the cell is going to shrink. The water, there's more sodium outside of the cell. The water is going to get pulled out. So let's think, if you eat chips, you have salty food, pulling water out of the cells, you become dehydrated. Hyponatremia, on the other hand, is a value of 135 or less, actually below 135. And in this case, the cell is going to swell and enlarge because of the lack of sodium. Let's go over some causes of hypernatremia. These tend to follow a pretty logical path. First of all, with the GIGU system, you can have hypernatremia because of decreased water intake, so the concentration of sodium is increased relative to the water content. You lose water content, so there's more sodium available. Um, Diabetes insipidus is a good example of this. And let's say you eat a lot of sodium, which we all do because our foods in the United States are packed with it. That is also a cause of hypernatremia. As far as like disease and illness goes, hormone imbalance, um, high or cortisol stress levels increases sodium and decreases potassium. Increased aldosterone due to primary aldosterone syndrome or Conn syndrome can also cause hypernatremia. So medications included in this would be hypertonic solutions and corticosteroids, both which can cause hypernatremia, as well as actually that is not supposed to be there. Burns is not there. Oh, actually no, Burns is there. Water loss with Burns. Um, Water loss with Burns, you're losing the water content, so the sodium rate value goes up in concentration. Hypernatremia is associated with hypokalemia. We're going to keep reinforcing that throughout this PowerPoint, so just be prepared for that. So signs and symptoms of hypernatremia. We remember fried, because fried foods tend to have lots of sodium, lots of salt. We're going to say no fried foods. F stands for fatigue. R stands for restlessness or agitation, really agitated, extreme agitation. I is for increased reflexes. These are the deep tendon reflexes. You might have muscle spasms, seizures, and coma at its worst. Obviously, we're going to have extreme thirst. This is due to high extreme thirst is due to the increased concentration of sodium. We want to balance that out. So our bodies stimulate our thirst reflex to increase water intake and balance this out. Decreased urine output, it's going to be obvious our bodies are going to want to be retaining water as much as possible. So the filtrate of urine is going to be very concentrated and minimal. We also might see dry mucous membranes and skin because of this dehydration. So let's talk about hyponatremia now. Um, so hyponatremia, this could be caused by a decrease in the consumption of sodium, rare, especially like I said in the United States where most of our foods are high in sodium. It could be due to vomiting. These vomitous secretions are very rich in electrolytes, so any vomiting is going to result in an electrolyte um, loss to the body, whether or not it makes a huge enough difference to throw the body's values outside of range. Who knows? But a lot of times you'll see NG suctioning causing the same type of issues because you're pulling all of those nutrients out of the GI system. Diarrhea, the same thing. You're losing electrolytes through um, the stool and as well as fluids. Some medicational causes of these would be thiazide diuretics. Um, some other things that can cause hyponatremia would be Addison's disease, so low aldosterone. Your blood pressure regulation is off. Um, Sodium and water are absorbed, and potassium is excreted under normal conditions. But in Addison's, the opposite occurs. The sodium and water are excreted, causing hyponatremia, and K is retained. um, High levels of antidiuretic hormone, like as seen in syndrome of inappropriate ADH secretion, SIADH, and also fluid overload due to congestive heart failure, hypotonic fluids, or renal failure can cause hyponatremia. Um, Another big one, an environmental factor is sweating. While you're sweating, you're losing copious amounts of electrolytes, so it makes sense that um, excess diaphoresis could cause um, lack of sodium. You taste that sweat, the sodium is salty. Hyperkalemia is also associated with hyponatremia. So remember, hypernatremia is associated with hypokalemia, and hyponatremia is associated with hyperkalemia. So these kind of have an inverse relationship, sodium and potassium. Some signs and symptoms of hyponatremia. We're going to remember salt loss because we don't have any salt. Seizures and stupor, uh, abdominal cramping, lethargy, decreased DTRs, deep tendon reflexes, trouble concentrating. We're going to have loss of urine and loss of appetite. We're dehydrated, and we also might see orthostatic hypotension or just hypotension in general. Our blood pressure is going to be low. We're in hypovolemia potentially. Um, we might have overactive bowel sounds. Shallow respirations are a very late sign. And then the last S here is going to be for muscle spasms. We think of sodium as having to do with muscles and contractions. So think about the runner at the end of the race who starts having contractions, muscle cramps, muscle spasms at the end of his race when the sodium has completely run out. Next up, we have chloride. This one is also concentrated in it's in higher concentration outside of the cell. Um, This chloride's main function is to maintain the acid-base balance, so it's a negatively charged ion. It aids with digestion and balances fluids. When we think of sodium, what do we think of? Sodium chloride. Good old normal saline. Um, yeah, so the normal range for chloride is about 95 to 105 milliequivalents per liter. And these levels are maintained through our kidneys, through sweat, and again with those GI juices. So, causes of hyperchloremia, we could see it with increased sodium intake. So, hypernatremia, we could see hyperchloremia as well. Um, we might see it with a decrease in our bicarb levels with diarrhea or vomiting. Um, we might see it in Conn syndrome, metabolic acidosis. We might also cause this when we are administering hypertonic fluids or giving corticosteroids. Um, and this can also be caused similar to hyponatremia um, or hypernatremia. This can be caused by not drinking enough water or losing water through some of those typical uh, GI fluids. So the signs and symptoms of hyperchloremia, we're saying it's very similar to hypernatremia. It's going to have also similar signs and symptoms. So let's just go over those again real quick. So hypernatremia symptoms are the fried foods. We're going to have fatigue, restlessness, really agitated patient, increased reflexes, DTRs. We might see seizure and coma in extreme cases, extreme thirst, decreased urine output, and dry mouth and skin due to dehydration. So, this let's think about hypochloremia just really quickly before we flip to the slide here. If hyperchloremia was associated with hypernatremia, we associate hypochloremia with hyponatremia. Um, this also would mean that vomiting, gastric juices, anything rich in sodium, mucus, sweat, those things we're going to lose or we're going to lose chloride. So we might see similar causes and signs and symptoms of hyponatremia in hypochloremia. Oh, and here we go. So GIGU system, we're going to have hypochloremia caused by vomiting. We're going to have hypochloremia caused by gastric juices being suctioned out of the patient, pancreatitis, remember, maybe other GI issue requiring no food or digestion to go on, maybe an ileostomy. These secretions are still rich in sodium and chloride, so as that fluid drains out of the ileum, you might lose some electrolytes. It's mainly sodium and chloride from that area. Cystic fibrosis, we see it through loss, we lose chloride through sweat and mucus production. Fluid volume overload in heart failure or syndrome of inappropriate antidiuretic hormone syndrome, whatever that is called. Um, and then we also might see it with metabolic alkalosis. So if you think about alkalosis, there's less chloride, which is a negatively charged ion. It's going to cause alkalosis. Um, yeah. Some medications that cause this are thiazide diuretics, and then again, those burns, anything losing fluid is going to cause this as well. Signs and symptoms are almost the same as hyponatremia. It's usually associated with one of the causes, so dehydration, tachycardia you might see due to that lack of fluid volume regulation, decreased blood pressure for the same reason, a fever. I'm not really sure why you might see that. Vomiting and diarrhea, you're gonna that's gonna be possibly one of the causes, but also you might see it as an effect. And then lethargy as well, like muscle weakness, that type of thing. Um, so um, next up, here we go. We have potassium. So potassium is concentrated mainly inside the soil, as we see here. It's got the exact opposite relationship as we said with sodium, inversely related. Um, these are found. It's found mostly inside the cell, maintained by fluid or maintains fluid balance, and its main gradient is maintained by the sodium potassium pump. It functions in muscle contraction and nerve impulse as well, and this narrow range 3.5 to 5 milliequivalents per liter is what we're looking for. Anything outside of that, first thing we do is obtain an EKG and monitor cardiac status. Hypokalemia. Hypokalemia, when we have not enough potassium, can be caused by potassium wasting diuretics, furosemide, corticosteroids, maybe too much insulin. Um, Glucose brings potassium into the cell as well, so we might lose potassium from our surrounding fluids. Cushing's disease, you're going to have an increased stress level, increased cortisol level, which is going to lower your potassium. Again, this inverse relationship, it's going to increase your sodium. You might also see hypokalemia caused by starvation or losing too much, again, through vomit, diarrhea, GI secretions, anything rich in electrolytes. So, signs of hypokalemia. Let's think hypo, low and slow. Hypo, low and slow. Lethargic, lethargy, and patient might be confused. You're going to have depressed respiratory status. You're going to have lethal cardiac dysrhythmias, ST depression, shallow T, and projecting U. Not sure how well we need to know all of these, but cardiac dysrhythmia is associated with K imbalance for sure. You're gonna have lots of urine, so your kidneys are gonna be dumping that. We can't concentrate urine without the proper balance of potassium. You're gonna have muscle cramps, decreased muscle weakness, or decreased deep tendon reflexes, as well as a low blood pressure and low heart rate. So let's look at the opposite now. With hyperkalemia, this would be when we are moving. Um, yeah, so this could be caused by burns, tissue damage, rhabdo, which is the when muscle tissue is broken down. It can be seen with Addison's disease. Renal failure is a very common one because you can't excrete the potassium sparing diuretics, ACE inhibitors, and NSAIDs. So for hyperkalemia, we're going to remember murder, muscle weakness, urine output is limited or little to none. Respiratory failure might happen. You might have decreased cardiac contractility, weak pulse, low heart rate, and then early muscle twitches and cramps. And then EKG again, always with the EKG, rhythm changes. Next up, we have calcium. Calcium is used for a lot of things, but primarily used in formation of strong bones and teeth, facilitates muscle contraction and nerve function, as well as is involved in blood clotting. I think it carries proteins. Protein does something with proteins. It's absorbed in the gut, and then anything excess typically is stored in the bones, and then we can break down that bone again and release calcium in times of hypocalcemia, minimal low calcium in our body, in our blood. Um, the normal levels for this are 8.5 to 10.5 milligrams per deciliter. And then also we always remember with calcium, vitamin D is involved in absorption. They're directly related to each other. You always group those two, vitamin D and calcium together, as well as vitamin C and iron, but it's a different story. Um, Regulation of calcium also involves the parathyroid hormone and then calcitonin. So these are parathyroid and thyroid hormones related to the regulation of calcium levels in our body. hypocalcemia causes, we can have decreased parathyroid hormone production due to surgery. Oftentimes, when a thyroid is removed, the parathyroid, which is a tiny little part um, near or up against the thyroid, is removed as well. And this can cause lack of calcium, low calcium intake, and low vitamin D because um, vitamin D is involved with the absorption of calcium, as we know. Lactose intolerance, you might see hypocalcemia because of the decreased calcium intake. Often these patients need calcium supplements from other sources. You might also see this with chronic kidney disease. Um, you might see this because of the use of biphosphonates. Um, they uh, lower the release of calcium, so the osteoclast, when they break down the bone, there's less calcium production. So if you're on biphosphonates, you're gonna not have as much release from the bones. Aminoglycoside antibiotics just waste calcium, goes straight through the body, it's not absorbed. And then anticonvulsants like phenobarbital also can cause hypocalcemia. With hypocalcemia, we're going to remember cramps. C for convulsions, R for hyperactive reflexes, A for arrhythmia, M for muscle spasms, P for positive Trousseau and Chvostek sign. We're going to go over those in a minute. And then S for sensation of numbness, tingling, or paresthesia. So you can see most of these are related to muscles. Um, yeah, but calcium is also involved in the long-term support of our bones. So Trousseau sign, when you inflate the blood pressure cuff around their arm, normally you're going to raise it up to above whatever their systolic is, and then hold it there for 3 minutes. If they draw that hand in, as you can see here in the diagram, kind of pointing at like a Italian chef or something, this is a positive sign. The fingers stay straight, but the wrist and knuckle joints bend. This is a sign of hypocalcemia and some other uh, electrolyte imbalances as well that we'll go over in a minute. Chvostek sign, when you tap on the masseter muscle, um, you're you're exciting that cranial nerve 7, and the facial muscles would contract or twitch if they are positive for hypocalcemia. Some causes of hypercalcemia now are hyperactive PTH, so that parathyroid hormone is causing the bones to release too much blood. They're breaking down that bones, osteoporosis. You might see this with increased vitamin D because you're having increased calcium absorption. You might see this in cancer because bone breakdown due to the medications given to a cancer patient will break down that bone and release calcium. And then you're also going to see this with thiazide diuretics and lithium, which is going to affect the parathyroid hormone. Okay. So some signs and symptoms of hypercalcemia. We're going to remember the word weak, W for weakness of muscles, very profound. So it's a weird one because I think of hypercalcemia, you're going to have crazy contractions, but it's the opposite. Nothing can contract. You're going to have a shortened QT interval in the EKG. You're going to have absent DTR, so you're not contracting. You're going to have altered level of consciousness and abdominal distension. There's no peristalsis going on. You're going to have kidney stone formation, hypercalcemia. The stones are crystallizing, turning into stones in the kidneys or other areas. Next up, we have magnesium. This is also concentrated within the cell. more highly than outside the cell. Its function is also with nerve and muscle contraction, relaxation uh, of these muscles, relaxation of blood vessels, and the sodium potassium pump. Most of it is or gained through our diet, absorbed through our gut, and um, the magnesium imbalances are typically associated with another imbalance, probably calcium or potassium in most cases. We have a very narrow range for magnesium at 1.5 to 2.5 milligrams per deciliter. So you can have hypomagnesia from not gaining or not eating enough foods with magnesium in it. You can have it from not having other electrolytes. Like we said, magnesium is related to calcium and potassium imbalances as well. Um, Malabsorption, you might not be uh, able to absorb that magnesium due to proton pump inhibitor or some other cause. And then we also see ETOH abuse as a cause of hypomagnesemia. The signs and symptoms we want to look out for are twitch. That's our acronym. So another positive Trousseau and Shostak sign. So that's calcium and magnesium that are related to these two. Um, this is going to be the blood pressure cuff and the tapping on the masseter, the muscle cranial nerve 7. You're also going to see weakness, increased deep tendon reflexes. You might see torsades. That's a lethal cardiac rhythm, seizures, or other EKG changes. Calcium and potassium levels. Let's reinforce that. So low potassium and calcium, low magnesium. Hypertension also associated with hypomagnesemia. Hy- hypertension because blood pressure regulation, right? Hypermagnesemia can be caused by trying to correct magnesium levels. So we administer a fluid or medication that is very high in magnesium, but otherwise it doesn't really occur that much. We give magnesium sulfate in labor and delivery. You might see it because of decreased renal excretion, end-stage renal disease, or severe renal issues, but for the most part, hypermagnesemia is not really found too much naturally occurring. Hypermagnesemia signs and symptoms would be lethargic. That's going to be our acronym. L for lethargy, E for EKG changes, T for tendon reflexes absent or diminished, hypotension, arrhythmias, red hot face and flushing, GI issues with nausea and vomiting, impaired breathing might cause skeletal muscle weakness that affects the respiratory system, and then confusion. Okay, I think it's our last one. Phosphate. Phosphate is involved in teeth and bone building as well. Stored in our bones, absorbed in our gut, excreted in kidneys, kind of like most of our electrolytes. Parathyroid gland is what regulates phosphate. Vitamin D influences phosphate. Like we said, calcium, potassium, vitamin D. Normal range for phosphate is 2.5 to 4.5 milligrams per deciliter. So if we don't have enough, this can be caused by aluminum antacids. We don't absorb enough phosphate, starvation and refeeding. So after you do not have food for a long period of time and then you're given food that increase in blood sugar, that rapid increase, um, you have to convert the glucose into energy requiring phosphate. So it's going to deplete all the phosphate stores you have. You know, we're making ATP, phosphate, adenosine triphosphate. You need phosphate for that energy production. So an overactive parathyroid can cause this as well. It stops reabsorption in kidneys, so you're going to dump the rest of that phosphorus. And then low vitamin D. Some signs and symptoms of hypophosphatemia would be bone pain and fractures, osteomalacia, neuro changes like irritability, confusion, and seizures, and then erythrocyte destruction. Hyperphosphatemia can be caused by phosphate laxatives, so you're putting a bunch of phosphate in these patients. High vitamin D. Rhabdomyolysis, you're going to be breaking down that muscle and causing a lot of phosphorus release. Muscle renal damage, if you can't excrete it. My grandmother actually takes a phosphate binder with her meals because she's on dialysis and needs to have that phosphate not absorbed in her gut because her kidney cannot excrete it. Hypoparathyroidism might also cause it. Some signs and symptoms of hyperphosphatemia include they're similar to hypocalcemia. So you're going to have convulsions, maybe seizures, hyperactive DTRs, muscle spasms, tetany, seizures, arrhythmias. You might have itching upon urination, and also you might have that positive Trousseau and Schwastek's sign. Thank you. That's my other references as well. There you go.